This is Andrea Kane, and I'm here with you for HIT 120 Pharmacology. We are now on week 2, and this week we are still continuing with the basics. We're finishing getting all of that foundational knowledge out of the way so that next week we can start talking about drug mechanisms, and week 4 we can get into starting to talk about specific body systems or systems on how drugs and medications work. So I will say that this should be another easy week, but next week when we get into drug mechanisms, that can get a little bit complicated. So let's enjoy this week while we have it. Starting off, let's talk about medical terminology as it has to do with pharmacology. In the last week, week 1, I'm not sure we covered a whole lot of terminology. I think there was some there. But this week we want to look at some specific ones. And in case you don't remember, for medical terminology, the root plus the combining vowel equals the combining form. And you can put a prefix in front of it and a suffix behind it to create those medical terms. So you'll see we're starting off with some combining forms and what their meanings are. We have arrow, algizo, broncho, chemo, crazo or crazo, cutaneo, dermo, ergo, aesthesio or aestheso, histo, hypno, iatro, linguo, myco, narco, oro, pharmaco, prurito, watch out for those two R's there, pyreto, theco, toxo, toxico. Notice there's 2 for poison, slightly different. Vaso, veno or vino, and veto. Now some prefixes that you may run across. Anna, anti, contra, pair or par, sin. So as you go through and you're looking at terms that have to do with pharmacology, just keep those in mind. You're going to need to know what they mean. Hint, hint, hint for your quiz. So talking about quizzes, a quick quiz. Which term means it prevents nausea and vomiting? Prevents nausea and vomiting. So as you can see, we have the prefix anti right here, anti, on all 4 of them. It's going to be the root behind it that's going to help you figure out which one prevents nausea and vomiting. I think you can get it. All right, so let's talk about medication administration. How is medication administered? I found this article. It's called Nursing Rights of Medication Administration. It's not that long of an article. I really want you to read it because some of the information is going to be included on your quiz this week. So make sure you read through and just have a basic knowledge of the article. When it comes to medication administration, there's anywhere from 5 rights to 12 rights to 13 rights. Different people have come up with different things. We're going to cover the 7 rights, somewhere sort of in the middle. This is kind of, I don't know, you'd say basic or foundational again. Yes, you can add to it, but you really can't take away from it. So let's start with the right patient. When you administer a medication, you need to make sure you have the right patient. The second thing is the right medication, then the right dose, and are you giving it at the right time, in the right way, through the right route? Are you giving it for the right reason? And then have you documented it appropriately? So that's what these are. You need to know these 7 rights. Make sure that you know them, that you're understanding what they're talking about. So patient is the individual you're going to be giving the medicine to. Medication is the drug itself. Dose is how much of it are you giving, or at what strength are you giving it. And then the time, is it too early, too late, on time? Are you giving it, is it supposed to be twice a day or every 12 hours? Is it, when you come to the route, is it something that you need to give by mouth, or is it something that needs to dissolve under someone's tongue? Those are two different routes. Both involve the mouth, but it's different when you give someone a liquid to drink versus or a tablet to swallow versus having them put something under their tongue to dissolve it. Again, whether you give a medication intramuscularly or subcutaneously versus in their IV, those are very different routes, but you need to know what the right one is, because nurses have given medications in the wrong route and it has killed people. Right reason. This is making sure that you've double checked that you've double checked the patient, you double checked the medication, you double checked the dose, the time, and the route. Are you giving it for the right reason? Does this patient still have this need for this medication? Has the doctor's order changed since you last checked? Those types of things. And then documentation. Have you documented exactly what you did? Are you using a barcode scanner to scan the patient's wristband and to scan the medication packaging itself, so you're making sure that it's credited to that patient as being given, and that the system is capturing the time and all of that. So make sure you know the 7 rights. Medication errors. Well, when you think about it, if you administer medicine, it is a process that can have errors in it, and not necessarily the person, but the process. So I want you to read this article about medication dispensing errors of prevention. Again, it's not a long article, but the concepts in it are things that I'm going to use in the quiz for you this week. So make sure you read it and that you understand most of what it's talking about. So let's talk about common medication errors. One of the most common medication errors is the wrong patient. It's failing to identify the patient. Oh, that patient's in room 451 or 452. Oh, well, the patient got moved between the last time you gave the med and the next time you gave the med, or maybe you came onto your shift, you gave the med to that patient yesterday on your shift, you go in today and it's a different patient. Did you ID the patient? If there's a room that has 2 beds in it, are you sure you're giving it to the right patient? How do you do that? Well, you make sure you have 2 forms of ID. If the patient is able to tell you their name and date of birth, that's great, but you better verify it with their bracelet. Again, you can have patients on the same unit who have similar names and dates of birth. I have sat in on safety calls that take place in most hospitals, usually a couple times a week, sometimes every morning, to talk about potential safety issues. And this is one that comes up from the nursing units. They have to read off, we have 6 sets of patients today on med-surg unit XYZ, and so here they are, both have the last name Smith. Then we've got a set that have the same date of birth and the same first name of Mary. And they go down the line and they talk about the fact that at shift change, this is what they cover between the nurses leaving and the nurses coming on, so that everybody's reminded, we have these patients, they have similar names or similar dates of birth or both. They're different patients. We need to be super careful when we're handling their meds. Wrong dose or time or rate. This can be an abbreviation issue if it's not clear, if it's handwritten. The wrong dose may be written down, not clarified by the nurse. Doctors make mistakes too. Nurses do as well. You have to stop and take the time to make a phone call and clarify it if it's not perfectly clear. And if it's an abbreviation for too much of something, absolutely it's got to be clarified. Distractions. Nurses and physicians are and extenders, they're all mid-level providers. They're all incredibly busy people. They have at least 5 or 6 things going on at the same time. One extra distraction too many, and it could cause a mistake in whatever it is that they're doing. If somebody's asking them a question, if they're writing something down, So it's really important that if you see a nurse or a physician or another provider and they're busy, wait until they stop what they're doing before you ask your question. Don't just walk right up and insert yourself into the situation, because that could cause a distraction. So you want to be really cognizant of that if you happen to be in a hospital setting or even a clinic setting and you've got busy providers and caregivers. Failure to review documentation for medication order changes. You could give a medication in the morning, and by afternoon, when you go to give it again 6 hours later, it could have been changed. If you don't go back and check the chart before you start your med pass, you can miss something. So it's really important to double check. Giving a med too late or too early can be an issue, because as we'll see next week when we talk about drug mechanisms and we talk about absorption, distribution within the body, and clearance, and how the drug is metabolized and eliminated through our kidneys, we're going to be learning about how too late, too early, a missed dose or an extra dose, how that impacts the medication and its effect in the body. And too much in the body can have a negative impact, and in some cases, too little in the body can have a negative impact. Setting an IV rate to be too fast or too slow can cause problems. So you've got all of those things when it involves dose, time, or rate that you need to be really careful of. Wrong drug or preparation of drug. A lot of medication errors have happened because medications may have names that sound or look alike, or they may have packaging that makes them look alike. And so this has been an alert, I would say, for the last 10 to 15 years in the medical field, with pharmacies and pharmacists, pharmacology, the government, to try and make sure that the packaging is differentiated, and that if you have look-alike or sound-alike drugs, they're not together in the pharmacy distribution machine that the nurses go to get the drugs. They don't put them next to each other because there's too much of a risk you might grab the wrong one. So you have to be really careful that when you pull a drug out of the machine to give it to a patient, that you're double checking it very carefully to make sure that you don't have a sound-alike or look-alike issue, that it really is the correct medication for that patient. When it comes to preparation of a drug, most hospitals prefer to have drugs prepared in the pharmacy. Nurses can do it in some cases, but what they have found is that, again, nurses have an awful lot of distractions, and sometimes they've had fatal drug errors because they've used the wrong diluent to reconstitute, or they've reconstituted with a right diluent, but it's too strong. So you have to be really careful when it comes to preparation of IV bags of a fluid that have a drug put into them, where it's diluting it down, that it's the right diluent, and that the reconstitution is to the right proportions. It's not too strong. And if you're not sure what the word diluent is, please take a moment to Google that and to look it up so that you can see all the different types. I'm not going to cover them here. We're not going to get to that level of detail, thankfully, in what we're doing with pharmacology. If this were a nursing program, oh mercy, you would definitely get into it. All right, so what are some implicating factors that they have found with medication errors? First one is miscommunication between providers. You can have as many as 7 to 10 physicians caring for very complex patients. Even some patients that are not complex, you can have 3, 4, 5 providers involved. When you think about the hospitalists and their rotations and specialists, consultants coming in, those types of things, there can be miscommunication. You can have a hospitalist who gives an order for medication. The consultant comes by and he thinks it needs to be increased, so he orders an increase. And maybe the nurse doesn't understand that they haven't talked, or that this increase should have been for a different drug or what have you. There's miscommunication and we end up giving the patient too much or not enough or whatever. Or maybe you have a situation where you have the hospitalist who is busy and forgets to prescribe the Lasix, and the consultant comes in and says, oh my goodness, you got to get Lasix going on this person, and I think we need to add a little extra because we need to get their fluid off and diurese them. And so all of a sudden you go from no Lasix to a big amount of Lasix, and there's miscommunication there. There's not coordination between providers as to what is the plan for the patient, and any medication change is signed off by both essentially. Doesn't have to be, but you have to make sure that kind of miscommunication, that the providers feel comfortable with each other and are paying attention to that. So for instance, if you had the hospitalist see the patient, the consultant see the patient, the hospitalist come back again, you want to make sure that they're talking through any changes that were made. And in some organizations, they tend not to allow consultants to make the changes. They tend to have the attending physician, which is usually a hospitalist, make the changes. So the consultant will recommend the changes, but may not order them. A different scenario would be in the ICU. A lot of times you have intensivists and you also have hospitalists working side by side. So you have critical care unit physicians like respiratory pulmonologists and things like that who have been trained in critical care medicine. And a lot of times they will take over the care for the hospitalist. The hospitalist will give recommendations instead of making the decisions. Miscommunication between nurse and provider. Again, the nurse thinks she knows what the provider is wanting. Maybe there's some kind of miscommunication or confusion there. If they both don't clarify the situation, you can have medication errors. And then one of the things that's most common across all healthcare facilities and organizations, including in the outpatient environment, is called fatigue alert. Or I'm sorry, alert fatigue. Let me back that up. Alert fatigue. And this is where providers and caregivers like nurses are getting so many alerts coming through the electronic health record all the time, and they get to the point where they just click through them. They're not reading them, they just click through them. They just click, click, click. I don't need this, click, click, click. I already know this, click, click, click. The problem is these alerts are built to remind providers and caregivers about allergies, contraindications, and food-drug interactions and drug-to-drug interactions. Things that are good in the sense that they're there to prevent medication errors or alert providers and caregivers. But because of alert fatigue, getting so many all the time for every patient, the providers and caregivers, like nurses, end up clicking through them, and they don't observe them. They don't read them. They don't think about them. They just click through. And so that's a problem with electronic health records that you'll see. Another quick quiz. Which term means preventing or reducing itching? Itch, itch, itching. So I will leave you to figure that one out. Now on to abbreviations. You need to know some of these abbreviations. I will tell you the ones of how often to give a medication. I will tell you how to give a medication. Those types of things are the ones you're going to want to study. I want to point out a couple things to you. This C, the line should be above it. The line should not be after it. It should be right above that C for with. Without is an S with a line directly above it. So make sure you know C with a line directly above it is with. S with a line directly above it is without. You do need to know CC, measurements, drug measurements. You would need to know that. Obviously FDA. So yes, definitely gram and things like drops and hour and bedtime and all those types of things you will need to know. So go through these, make sure you're very familiar with them. Oh, it brought up another P. The line should be above it for after. If it's before, it should be in a little a small lowercase a with a line above it for before. It means ante, A-N-T-E, ante is before. And post, which is what this P with the line over it stands for, post is after. And if you studied Latin, you would learn that in your Latin class. That's where I know it from, but you may find it other places. I want to go back to this. They put here AC. So the A alone, if it were A alone, a little A alone with a line above it, that would be before, ante, before. C here has to do with meals. And so the only time you're going to see it is before meals and after meals. So AC is before, PC is after, and you don't need the line above it. The only time you use the line above an A or a C or a P or an S is when that letter is there alone, just to clarify. So you see S here as well. The line should be above. And I have never, ever in my 25 years in healthcare ever seen SOS. I will tell you that right now. I have never seen that as an acceptable abbreviation in a medical facility or ever used in a medical facility, but it's here. And it's not one you need to learn, but I'm going to point that out as I don't know where in the world they got it, but yeah, I have not seen that one. All right, which abbreviation means 4 times a day? I think you can get this, especially if you go back and you take a look. All right, now we talked about abbreviations. Did you know there's banned abbreviations? There is an official do not use list. And this list has been around, oh, mercy. Oh, at least 15 years, maybe longer. But yeah, it's been around. Well, I guess, yeah. I don't know if Joint Commission lists when they first started it. Has nothing to do with this copyright down here, by the way. That's from something else. But this is the current list, do not use list from the Joint Commission, and it goes through, these are abbreviations that they have found that cause problems, that when they are handwritten or on pre-printed forms or used in free text computer entry, they have documented medication errors with. So unless you're using EHR, EHR CPOE systems, where it's very clear, it's not something that can be handwritten in or circled or anything like that, anything outside of that EHR or CPOE system, you can't use these abbreviations. You're not supposed to because they have caused medical errors. So let's talk through what they are. U is unit, but sometimes it can be mistaken for the letter or for the number 0 or the number 4 or for CC. So they want you to write unit instead. IU, International Unit, has been mistaken for IV or the number 10. You should be writing International Unit out. QD, meaning daily, or QOD, which means every other day. Both of them have been mistaken for each other and for other things. You need to write out daily and write out every other day. Now we get to trailing or leading zeros. A trailing zero is what comes after the decimal point or after the number after the decimal point. And they give you the example. If instead of, and in fact, I'll do this on the next slide. I'll go over trailing and leading zeros there because it is a question. But notice, it gets very confusing. They want you to either write the number with no decimal behind it or write a leading zero, the decimal, and your number. Notice there are no other zeros behind here, especially after this decimal point. They want the number, not a zero. So if the correct number was 0.0x, that's fine. But 0.x0 is not fine. And the same thing up here, you don't want x.0. No, you just want x. All right, mag sulfate or morphine sulfate, which is it? Or is it multiple sclerosis? That's a diagnosis, but still. MS. Unfortunately, morphine sulfate and magnesium sulfate have been exchanged, causing fatal medication errors. So, if you're going to use morphine sulfate, write it out. If you're going to use magnesium sulfate, write it out. Do not try and use the chemical definitions because, again, they're too close to be called. All right, there are exceptions to the trailing zero, but that's when you're talking lab results, imaging studies that are reporting the size of lesions, or catheter tube size, not in medication orders or medication-related documentation. Notice that. Do not use is for medication-related documentation. All right, so let's talk about the, whoops, which way did I go? There we go. All right, which abbreviation is not a banned dosage? Okay, first one out of the gate we know is banned because you've got a decimal without a leading zero. So A is out. Mark it out. Next one, you've got 5, but you've got a decimal and 0. Is that allowed? No. If you've got a number and you don't need the decimal point, and you don't need the 0, so mark that one out. A and B are out. They are banned. Let's jump down to D. Why would D be banned? You have the leading 0, you have the decimal point, and you have the 5. But you don't need these following zeros. They only confuse the matter. They don't simplify it. They don't keep it easy to understand or read. This one's out as well. So the correct answer here is C. C is not a banned dosage. Do you understand why A went out? No leading 0. And then we had a trailing 0 here. And then we had 2 more trailing zeros here. So that is why C is correct. All right, what's the difference? Prescriptions versus medication orders, are they the same thing? No, actually they're not when you get down to it. A prescription is a list of medications or other advice given to patients in the outpatient setting. A prescription is an instruction for a pharmacist to carry out and then educate the patient on. A medication order is an instruction for medication to be given to patients either in an inpatient or an outpatient setting. A medication order is an instruction for a nurse to carry out and then educate the patient on. Notice that. Prescription, outpatient only, pharmacist. Medication order, inpatient or outpatient, nurse to carry out. So some types of prescriptions. We're almost done here, so hang on. We're almost done. I think this is one of our last slides, so we're getting there. The 3 most common types of prescriptions or types of medications prescribed these days are opioids, central nervous system depressants, and stimulants. I got that from an article online looking at a couple of different sources to identify that that's really what's happening. And then I gave you some examples in parentheses. But the common types are opioids, CNS depressants, and stimulants. And if you wanted to know, well, what is an opioid? Well, a type of opioid is Vicodin or OxyContin. Those are brand names. Same thing with Valium and Xanax and Ritalin and Adderall. Categories of medication. Now, this is something I want to take a minute on here because this is something you really need to know. There are 4 categories of medications. There is what is called general sales, also known as over-the-counter medicines. Over-the-counter medicines. Tylenol, Motrin, Advil, some allergy medicines like Benadryl. Those are all over-the-counter general sales. They don't require a prescription. There's something you can walk into any store that sells those and buy. Pharmacy medicines are ones that are kept in the pharmacy. They do not require a prescription to dispense, but they're managing those medications. Do you remember a couple years back when there was a real problem? It might even be as far as 10 years ago now, where meth was being made by people who got Mucinex DM, and then they boiled it down and made meth. However they did that, I have no idea. But I was living in North Carolina at the time, and it was a real problem in some parts of the Appalachian Mountains. And since we were only 20 minutes from the mountains, sometimes we were made aware of some of that happening. And so there for a period of time in the state of North Carolina, if you wanted to buy Mucinex DM, you had to go to the pharmacy. They would sell it to you without a prescription, of course, because it's an over-the-counter medication, but they would scan your driver's license and track how much you were purchasing, to try and identify where people were purchasing huge volumes of this stuff, probably for nefarious reasons. So that would be an example of a pharmacy medicine. Another example might be diabetic supplies. They're kept over in the pharmacy, needles, those types of things. Oh, they're not really needles, but you know what I mean. To prick your finger, to take your blood sugar. And those are often kept behind the pharmacy counter. Again, you don't need a prescription, but the pharmacy itself, the pharmacy area itself, even within the pharmacy, is the one that dispenses those. So that's a pharmacy medicine. So those examples there, they do not require prescriptions. The difference is general sales is out on the shelf. You just grab it, go pay for it, and off you go. Pharmacy medicines, you present yourself to the pharmacy part of the pharmacy and from behind the counter, and they'll get it for you, and you can still buy it without a prescription, and off you go. Prescription only medicines, you need that doctor's prescription to present to the pharmacist in order to obtain it. Example would be antibiotics, and those types of things. Any of the ones above that we talked about, the CNS depressants, the stimulants, those types of things. Unfortunately, opioids and those CNS depressants, and I'm not sure about the stimulants, we'll find out when we get to that point, but they also fall under what's called controlled or scheduled drugs. And we will talk about those. I'm trying to see which week we will get there. Next week. Week 4. Week 4, sorry. Got excited. Week 4, we'll talk about controlled or scheduled drugs, and we'll go into that in depth. Because yes, you have to have a prescription for those, but there's some additional hoops to jump through. So prescription-only medications and controlled or scheduled drugs, you have to have a physician prescription to obtain. They are kept in the pharmacy and only dispensed appropriately. If you do controlled or scheduled drugs, there are some additional hoops you have to jump through in order to obtain those. So hopefully that makes sense on the categories of medication. We are now at the point of review questions. So I'm not going to go over these, but they are here for you for your quiz to help you prepare. You need to know the answers to all of these review questions, and there's 3 pages of them, as you can see. Here's page 2. And page 3. All right. So that's what you have for this week, which is week 2. We are still on those unit objectives that are listed out for you on your week introduction. Hope you're having a great week, and I'll be back to talk to you again soon about week 3 with drug mechanisms. Take care.